Does telehealth rehab before and after ICU discharge improve survival and quality of life for critically ill patients? Which new diabetes medications can be added to basal insulin to improve glycemic control without raising hypoglycemia risk? What's the latest evidence for sodium bicarbonate or high-dose vitamin C in the hospital? This and much more on today's JAMA Editor's Summary. Hello, and welcome to our listeners around the world. Today is Friday, June 12th, 2026. I'm Dr. Kirsten Bibbins-Domingo, Editor-in-Chief of JAMA and the JAMA Network. Today, I'm joined by Dr. Linda Brubaker, JAMA Deputy Editor, and we're also joined by JAMA Associate Editor, Dr. Christopher Seymour, to discuss the latest JAMA research featured in this year's Critical Care Reviews meeting in Belfast, Northern Ireland. Let's get started with a new randomized trial looking at telehealth rehab that starts in the ICU and continues after discharge. Welcome, Chris. Can you tell us about this first trial?
Hi, Kirsten and Linda. Recovery after acute hypoxemic respiratory failure often leaves patients with long-term impairments and poor quality of life. Many interventions fail to make a meaningful impact for patients when provided at a single time in recovery. But the value of coordinated rehabilitation across the ICU, hospital wards, and post-discharge period is still uncertain. Dr. Rosa and the Tele-Rehab Trial Group conducted a stepped wedge cluster randomized trial involving over 1,900 adults in 20 Brazilian public hospitals who required invasive mechanical ventilation. The intervention bundled telehealth-based rehabilitation throughout the ICU stay, during care on the medical ward, and then in a post-discharge program. The primary outcome was health-related quality of life at 90 days after hospital discharge, measured by the EuroQol 5-dimension 3-level utility score, also known as the EQ5D 3L score, where a score of 1 represents the optimal state of health. At 90 days post-discharge, the mean quality of life utility scores were greater in the intervention group compared to usual care, 0.16 versus 0.12 on the EQ5D scale, a result that was statistically significant. The authors conclude that delivering a coordinated telehealth-based rehabilitation pathway improved quality of life at 3 months. And for many hospitals, including those in resource-constrained settings, this study shows real-world benefit of investing in multidisciplinary, staged rehab programs that extend recovery support beyond the ICU stay.
Yeah, this seems to be an important demonstration of how team-based, continuity-focused care could reshape the recovery story for many patients after mechanical ventilation.
And we also have a randomized trial that puts some long-standing critical care practices to the test. Let's look at the study of high-dose IV vitamin C for major burns.
This paper caught my attention because severe burn injury leads to a cascade of inflammation, organ failure, and high mortality. For years, medications like high-dose intravenous vitamin C has been suggested as a way to buffer this cascade and possibly reduce intravenous fluid needs. But strong clinical evidence has been missing. So now we have the International Victory trial, led by Dr. Stopp and colleagues, which randomized 238 adults with severe burns across 24 burn centers on several continents. Patients received either high-dose intravenous vitamin C at 50 milligrams per kilogram every 6 hours for 96 hours, or they received placebo. The primary outcome was a composite of 28-day death or ongoing organ dysfunction. The results were unexpected. The vitamin C group had a higher rate of the primary outcome, 41% versus 30% in the placebo, crossing the trial's futility and harm boundaries at the interim analysis, leading to cessation of enrollment in the trial. In fact, the hospital and ICU deaths were also higher in the vitamin C group, and there was no improvement in time to hospital discharge, other organ dysfunction outcomes, or quality of life. In other words, high-dose intravenous vitamin C did not help and may even be harmful for patients with severe burns. In short, this medication should be abandoned for routine burn resuscitation.
This is a major message for burn and ICU teams worldwide. A common intervention that was considered low risk may worsen burn resuscitation outcomes. Kirsten, there's also an accompanying editorial by Dr. Greenhalgh.
Yes, Dr. Greenhalgh says this trial should put a stop to high-dose vitamin C outside of research settings for major burns. He notes that historical arguments for its use, based on observational data and theory, must be reconsidered now based on this evidence.
Let's continue our theme of challenging routine interventions in acute care. Let's turn to sodium bicarbonate for in-hospital cardiac arrest.
Sure thing, Linda. In-hospital cardiac arrest is a dramatic event in the patient journey, and survival is still low. Sodium bicarbonate is often used to address metabolic acidosis during cardiac arrest, but there's really been no solid evidence that it improves outcomes for in-hospital arrests. Using data from an out-of-hospital cardiac arrest trial, most guidelines recommend against its routine use. Nonetheless, the administration of bicarbonate during in-hospital codes is quite common. Dr. Granfeldt and the Brubaker group conducted a large double-blind RCT in Denmark. They randomized 779 adults with cardiac arrest in the hospital after each of the first 2 doses of epinephrine to receive either 50 millimoles of sodium bicarbonate or placebo as soon as possible. The main outcome was the return of spontaneous circulation, defined as a palpable pulse or other signs of circulation with no further need for chest compressions for at least 20 minutes. The authors report no difference in return of spontaneous circulation between groups, 39% for bicarbonate and 37% for placebo. They conclude that routine sodium bicarbonate during in-hospital cardiac arrest did not improve return of spontaneous circulation or longer-term outcomes.
In an accompanying editorial, Dr. Calloway notes the long-standing reliance on clinical intuition and tradition for sodium bicarbonate administration and urges clinicians to accept the solid trial evidence that now shows no routine benefit or even harm.
Finally, let's turn to new pediatric ICU evidence. The Gastric PICU study tested whether clinicians should measure gastric residual volumes to decide on the feeding approach for critically ill children.
Linda, this study addresses a commonly encountered issue in the pediatric ICU. Nurses and clinicians often stop or slow tube feeds in kids when residual volumes are high, hoping it will prevent vomiting or aspiration. And although strong evidence in adults tell us the practice should not be used in adult intensive care, there's little evidence for the value of this practice in children. Now, Dr. Toom and the team randomized 4,700 invasively ventilated children in 22 UK pediatric intensive care units to either have gastric residual volume assessments every 6 hours or no routine checks at all, only using clinical monitoring for feeding intolerance. The clinical co-primary outcome was a composite of survival and days free from mechanical ventilation at 30 days. In their large trial, skipping routine residual measurements had no effect on the composite outcome of ventilation time plus survival at 30 days. And in fact, children in the no assessment group reached 80% of their calorie targets at 72 hours versus 77% in the control group and had less time off tube feeds.
Wow, that's practice-changing evidence for thousands of PICU clinicians all over the world. Kirsten, there's an editorial on this trial as well.
Yes, Drs. Barris and Murthy comment that routine aspiration is a clinical myth that's persisted despite minimal data. They call for de-implementation, noting that de-adopting low-value care is difficult but essential for staff workload and patient nutrition. This trial should help finally tip the balance away from routine gastric residual volumes measurement for most ventilated children. That wraps up our CCR 2026 content for today. Thank you for joining us, Chris.
Thanks. It's great to see so many trials at JAMA that will directly inform what we do tomorrow when caring for the critically ill.
Okay, let's shift to a policy study for people with diabetes dependent on insulin.
Well, out-of-pocket insulin costs in the U.S. have become a major barrier to adherence, especially for people on Medicare. The 2022 Inflation Reduction Act capped insulin prices for Medicare patients at $35 per 30-day supply, beginning in 2023, but the full impact wasn't clear. Dr. Meyerson and colleagues analyzed a national sample of nearly 2.9 million Medicare Part D insulin users, comparing trends before and after policy implementation. They report strong evidence that out-of-pocket caps can reduce cost-related rationing, at least for Medicare Part D beneficiaries. This policy stabilized insulin costs and helped those previously at risk for underuse due to expense use their insulin correctly.
In an accompanying editorial, Drs. Essien and Bayef put the findings in a wider pharmacoequity context. They point out that while cost caps are a major step, real-world adherence is shaped by many forces, including polypharmacy, comorbidities, and systemic disparities. Oftentimes, groups that are affected by these factors may already be on other affordable plans, and this study points out that policy alone may not address ongoing equity gaps. Linda, as you know, JAMA just hosted a major summit on obesity. Let's talk about a major new trial from China that evaluated the effect of Mazdutide, a dual agonist of the GLP-1 and glucagon receptors in adults with moderate or severe obesity.
Obesity rates in China are rapidly rising, and many people have BMIs over 30 with high cardiometabolic risk. This Phase 3 double-blind RCT by Dr. Gao and the Glory 2 investigators randomized 461 adults with a mean BMI of 34 to either 9 milligrams once weekly Mazdutide or placebo for 60 weeks, plus low-calorie diet and activity advice. At 60 weeks, the Mazdutide group lost an average of 16.7% of their body weight compared to just 1.5% for placebo. Over 84% of participants receiving Mazdutide lost at least 5% of their weight. Significant improvements were also seen in waist circumference, blood pressure, and lipid profiles. The main adverse events were gastrointestinal, vomiting 53%, nausea 47%, and diarrhea 39%, mostly during dose escalation. Nearly 3% stopped the drug for adverse effects.
Let's take a look at a new Phase 3 trial for type 2 diabetes. Insulin is a mainstay for advanced type 2 diabetes, but intensifying insulin often means more weight gain and risk of hypoglycemia. This trial evaluated Orforglipron, an oral non-peptide GLP-1 receptor agonist added to titrated insulin. Orforglipron offers a new approach without injections.
In this double-blind, 40-week ACHIEVE-5 trial, led by Dr. Giorgino and colleagues, over 500 adults with inadequately controlled diabetes on insulin Glargine were randomized to once daily Orforglipron at 3, 12, or 36 milligrams, or placebo, in addition to treat to target basal insulin. At 40 weeks, mean hemoglobin A1C reductions ranged from 1.6 to 1.9 percentage points with Orforglipron, compared to 0.8 with placebo. All doses were superior to placebo. Body weight dropped 3 to 5%. Rates of clinically important hypoglycemia were not higher compared to controls. Gastrointestinal side effects were the main adverse events, most often in the escalation phase, but discontinuations for these were under 10%. The authors conclude that oral Orforglipron can meaningfully improve glycemic control and weight when added to basal insulin without more hypoglycemia.
The editorial by Dr. Gaddy and colleagues puts ACHIEVE-5 in context as part of a growing menu of effective options for type 2 diabetes and obesity. They underscore the value of new oral agents, which can be easier for patients than injectables, especially in the setting of complex multimorbidity and polypharmacy. Linda, let's turn briefly to an important research letter tracking NIH-funded investigators.
From 2016 to 2024, the number of NIH-funded principal investigators grew steadily. However, Dr. Nguyen and colleagues report that in 2025, that trajectory reversed. total number of research grant PIs decreased by 4%, and fellowship holders by nearly 10%. The largest relative drops were among Black and Hispanic investigators, especially among trainees. This reversal raises concerns that budget cuts and workforce disruptions are hitting underrepresented groups hardest and may threaten future diversity of the scientific workforce.
Let's move on to opinions in the Viewpoints and Perspectives section of the journal published this week. In their viewpoint, Dr. Edwards and Rathore examine the resurgence of tetanus in the U.S. and the ongoing importance of vaccination. They note that despite decades of vaccine success, recent CDC reports show an increase in tetanus cases and deaths, especially among unvaccinated elderly and children. The message in this viewpoint is clear. Without herd immunity and amid declining pediatric vaccination rates, maintaining high coverage with tetanus vaccines remains essential to protect all ages.
There's also a thoughtful viewpoint from Dr. Volbrecht and colleagues discussing, quote, slow life support, unquote, in critical care. They describe situations where clinicians continue some support, but withhold major interventions in dying patients, sometimes without full disclosure to families. The authors urge clinicians to be transparent about limits, explicitly acknowledging these choices, and involve open communication to avoid confusion or inequity at the end of life.
And Drs. Adjoa and colleagues have a timely viewpoint on the rise of patient-driven AI health tools. With new products allowing patients to upload their entire electronic health record into commercial LLMs, there's a clear opportunity for better individualized care, but also substantial risk. Privacy violations, misuse of personal data, and perpetuation of electronic health record-driven bias. The authors of this viewpoint call for stronger legal protections and more transparency, as well as researcher access to monitor LLM outputs for safety and bias.
Drs. Casaletto and Dubal reframe how we talk about women and Alzheimer's disease in their Insightful Perspectives article. The authors highlight that despite higher lifetime risk and greater pathologic burden, women also show clinical resilience with better memory function and longer survival despite the pathology. This piece emphasizes the need for sex-specific research to understand and leverage female brain resilience rather than seeing women only through a lens of increased vulnerability.
This week's long review is a deep dive on adult survivors of cyanotic congenital heart disease, led by Dr. Essenza and colleagues. Their comprehensive review describes how many people now survive into adulthood after surgical repair of complex congenital heart disease, but often develop valve problems, arrhythmias, or heart failure, and need ongoing multidisciplinary care. Attention to both medical and psychosocial needs remain essential throughout the lives of these patients. This week's Clinical Reviews podcast highlights these issues in a conversation with the review co-author, Dr. Landsberg, and JAMA associate editor, Dr. David Seimel. Let's take a listen.
When we look at why kids have survived well into their adult years, we don't have data to say that it's the cardiologists or the cardiac surgeons who have made this happen. The answer that we've consistently found is that it's coordinated care at large comprehensive medical centers that engage in all consultants, primary physicians, internists, and support staff who together have allowed for well-being and continued survival.
There's also a JAMA Insights update on exocrine pancreatic insufficiency by Drs. Ramsey and Forsmark. Exocrine pancreatic insufficiency is most commonly caused by cystic fibrosis, chronic or acute pancreatitis, pancreatic cancer, or pancreatic surgery. This review summarizes the latest screening and treatment for this condition.
And the JAMA patient page covers adults with mild to moderate hearing loss, summarizing the pros and cons of prescription versus over-the-counter hearing aids, the role of hearing assistance devices like earbuds, and the importance of addressing hearing impairment to reduce dementia risk.
Before we wrap up, I want to remind listeners that the JAMA Medical News podcast publishes every Friday and gives our listeners insight into the latest medical news. You can subscribe at jamamedicalnews.com or click on the link in this episode's show notes.
That's a wrap for this week's JAMA Editor's Summary. Thank you, Linda, and thanks to our listeners for tuning in to hear what's new at JAMA this week. These highlights were brought to you by Dr. Linda Brubaker, Dr. Christopher Seymour, and me, Dr. Kirsten Bibbins-Domingo. This episode was produced by Shelley Steffens, Daniel Musisi, Dr. Krista Roberts, Dr. Michael Lipnick, and the team at the JAMA Network. A link to this JAMA content can be found in the episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thank you for listening.
The script for this podcast was generated with assistance from GPT 4.1 OpenAI tools following an editor-developed prompt. The script was then reviewed, edited, and approved by editorial staff. This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.